Traditionally, we begin our conference with the Reiner and Julie Martin's invited lecturer. This year's lecturer is Pamela S. Hyde. Pamela Hyde was nominated in November 2009 by President Barack Obama and confirmed by the U.S. Senate as Administrator of the Substance Abuse and Mental Health Services Administration, an operating division of the U.S. Health and Human Services Department. She served in this role until August 2015. During these 6 years, she championed policies addressing behavioral health issues in disaster preparedness and response, suicide and gun violence prevention, prevention and treatment of addiction, early intervention and recovery support for persons with serious mental illnesses, and prevention and treatment for children, youth, women, and persons in the nation's justice and human services systems who've experienced trauma and its consequences. Prior to her work at the Substance Abuse and Mental Health Services Administration, Ms. Hyde served from 2003 to 2009 as the Secretary of the New Mexico Human Services Department, responsible for Medicaid, food stamps, child support enforcement, behavioral health, and other state and federal programs. A lawyer by training, Ms. Hyde has had 35 years' experience in policy management and consulting for public sector systems of healthcare and human services. She has consulted with state and local authorities and provided networks in over 15 states and more than 25 different jurisdictions. She has written articles and delivered speeches nationwide on evidence-based practices and thinking, the status of insurance coverage in the United States, gun violence, cultural issues, and leadership needs for behavioral health programs and services. Ms. Hyde has served as a policy consultant to many national organizations, including the John D. and Catherine T. MacArthur Foundation, the American College of Mental Health Administration, the President's New Freedom Commission on Mental Health, and the United States Department of Justice. She has received awards from the American Medical Association, the National Governors Association, the Seattle Management Association, and a number of consumer and provider organizations for her leadership and creativity and for her commitment to the well-being of those who rely on publicly funded health and human services. Please join me in welcoming Pam Hyde, who will deliver the Martin's Lecture entitled The Patience for Policy, Building Networks to Make a Difference.
Good afternoon or evening, whatever you're experiencing, depends on where you are from in the country. It's a great honor to be here, and thanks to Debbie and to Kathy and Kim, and also thanks particularly to Bobby Bennett, who's a friend of mine who's got me connected to Kathy for this evening. I think probably, instead of calling this the Frontiers in Kinesiology Conference, the speech should be Frontiers for Kinesiology. I want to talk a little bit about, why me? Why am I here? Who am I and why am I here? Why would you invite a lawyer, political scientist, somebody who's been working in healthcare but also human services and housing for these many years, and I'm clearly not a kinesiologist. I'm not an academician. I don't tend to be very patient about policy. One could say I'm a cynic or I'm experienced, whichever one you want to say. But I have often been, for whatever reason, asked to be in rooms with academicians who are working on research, new knowledge about areas that I was responsible for. And I want to tell you a little story. I think this is something that happened to me that was just sort of the basics about this difference between policymaking and academicians or people who are bringing new knowledge to the world, but how do you get that translated into actually actions? I was in a group of academicians. I was supposed to be the real person in the room. And we were talking about case management. This was way back in the 1980s when case management was a new concept in healthcare and behavioral health. And an academician looked at me and said, "But don't you want to know if case management works before you do it?" And I said, if the legislature gives me $5 million to do case management, no, I don't want to wait to know if it works before I do it. Now, I may need help knowing whether what we do had any impact, but the concept that you have to wait until you have all the knowledge and before you can do policy just isn't real. So for me, that is kind of sort of the idea behind policy. And what I want to talk to you a little bit about tonight is what policy is, how it's done. Some of this probably is going to be like, mom and apple pie. You're going to know some of this. But I want to put just a little bit of a different twist on it from my experience and how you might think about it just a little bit differently in order to make the difference that I know you want to make. I want to talk about ways to influence policy and some current opportunities for affecting public policy, especially in my world. I do come from health, and particularly from behavioral health. I think there's a real opportunity for some connections here, but a lot of what I want to tell you about, I hope you'll use as examples of how you might do things in whatever world you're trying to make a difference in. And then just very quickly, some policy challenges for you. So let's start with what policy is anyway. It's a principle, a rule to guide decisions. That seems pretty straightforward. It assumes a decision, and it frankly assumes rationality, which is not true. Policy is not necessarily rational. It's a purposive course of action, authoritative allocation of values. That assumes there are values behind it. That assumes action. It assumes a matter of purpose. And sometimes that's true and sometimes it's not. Public policy, obviously, is a difference between anybody's policy, and I'm going to make a point about that in just a second, versus what governments do. And we like to assume that our government is working on behalf of the whole of society. That also is not true. Governments, just like anything else, has interests. It assumes goodwill. That's not necessarily true. It assumes the best interests of everybody in mind. That's not necessarily true. And it assumes an impact, which usually is true, but sometimes the impacts are unintended, and I'm going to make a case about that in just a second as well. So this, policy issues are, by and large, public policy issues are determined by political actors. And political actors are not objective analysts. So they don't take research and say, I wonder what the best thing to do in this situation is. Let's pick the most well-known, researched, most clear thing, and let's try it. Doesn't work quite that way, although the MacArthur Foundation, the Pew Foundation, and some other foundations have tried really hard to work on rational public policy and evaluation of public policy. And I'm going to, again, make a case that while that is a good thing to do, it is not always the best place to think about impacting public policy. And frankly, as people who care about what's right, what the knowledge is, we have a tendency to focus there on the evaluation or policy considerations and what the research tells us, not the way policymakers usually think. So let's talk a little bit about that. So policy is written or oral. It's a practice, it's a law, it's a reg. It is not necessarily rational, effective, good for the whole, or it's not necessarily enforced, as a matter of fact. Sometimes in government, anyway, it's easier not to do something. Now, people sometimes get in trouble for not enforcing regulations or things of that nature, but a non-decision is also a public policy sometimes. It just may be a little more under the radar. Now, I want to make a point here about who makes policies, because I think every one of you in this room is probably trying to impact individuals about how they live a fit life, a healthy life. You're trying to impact families, communities, organizations, governments, et cetera. So let me just take a couple of examples, because I want to help you think, or think with you about how policies might be formed and why. So an individual might say, I only exercise indoors. Quite frankly, my father's wife says this. Now, you could make up all kinds of reasons why somebody might say that. But knowing why my stepmother says that is going to have a big impact on whether you can change her policy or not. Same thing is true with these other examples. If an individual says, I don't eat red meat, well, you need to know whether that's a political statement, an environmental statement, a cost statement, or what's driving that person to make that policy. Because if you approach them from an environmental issue, and it's really a cost issue, you're not going to get anywhere. So understanding what drives the policy is really important. Families might say, we always go to church on Sundays. Or they might say, we always eat dinner together. Now, we might always eat dinner together because we understand the research about families who eat together and how much better the kids turn out. Or they might do it just because they got raised that way. So you can't assume that policy is made on the basis of knowledge or on the basis of what the research tells you. I really want to pay attention to this one that's in red because it's something in my field that's important. Increasingly, parents are slathering sunscreen on everything from their babies to their young kids because they've understood that there's an impact for them later in life. Actually, the research tells us that there's much more likelihood of a young person's experience or exposure to trauma and their later health than their exposure to sun and their later health. But parents have figured out, have learned that they should put sunscreen on their kids. We have not yet taught them that they should do protective issues and protective factors in order to make sure their children are protected against the impacts of trauma that every child experiences, no matter how good a family or how good a community. So understanding how people think about this is important. Some other examples about organizations in government, legislative body, this example I want to make the case about people who drink and drive will lose their driver's license, but so will non-custodial parents who don't pay their child support. These policies are not about driver's licenses. They are about people not dying on the streets, on the roads, and they're about people who don't pay their child support. So assuming or understanding what the policy is about is not as obvious as it may seem. Executive or implementing bodies. I love this one because I've been in this role much of my life. All grants have to be evaluated. That sounds like a good policy. Well, to tell you the truth, if we are doing an evidence-based practices, we've been doing it 20 years, we're giving grants out for it, it still works. Spending public money to evaluate it one more time is probably not the best policy. And yet, if we don't do it, we get dinged big time as executives in government for things like that. So again, we can use all these examples. The one on the bottom is probably a big public policy around the way courts work and the idea of precedent and why things like Roe v. Wade doesn't get overturned, or things, why it's so important when the Supreme Court makes a decision like the gay marriage decision that they made recently, because those laws and those court decisions will not get overturned lightly, because to do so would create chaos in our society, and we don't even think about that critical legal policy. That there's a lot written back about in law, but it's not like Congress decided this. It was decided as a practice to make society work. All right, finally, I want to make the point here that who makes policy has something to do with who has the power to do so. So if I'm a domestic violence perpetrator and I say you will have dinner on the stove or on the table when I get home, that's one thing. If I'm a dad or a mom who says, teenage daughter, you need to help around here, you will have dinner on the table when I get home because I'm trying to teach you something. So again, the difference is important about who does it and why. And all these examples, and you can read them, all these examples have different implications about who has the power to make that policy and why they do it. And here I want to make the point, never underestimate a staff person for a policymaker. Probably the most important people to know are the secretary, and I mean the administrative assistant, and the special assistant. Those are the two most important people to know if you're trying to impact a congressperson, a federal official, or anybody else. So never underestimate those folks, and never underestimate the people who are putting in front of policymakers the data, the options, and the potential choices. That's networking of a different sort that we don't often think about. We want to be in the room with other academicians. We want to be in the room with other policymakers. We want to be in the room with congresspeople or the president. I want to be in the room with a special assistant because that's what's going to make the biggest difference. All right, let me give you a couple examples of unintended consequences. I made a decision as the SAMHSA administrator, so Substance Abuse and Mental Health Services Administration is what I spent 6 years being the head of in DC. I made a decision that we would provide grants where we could to states rather than to nonprofits. It wasn't because I didn't like nonprofits, it's because I was in a context in which the president was trying very hard to get all the states to implement the Affordable Care Act, and we had been told by the Supreme Court that there was a big hammer that we couldn't use. Okay, so in that context, we were trying everything we could to get resources to try to influence states in the decisions that they made. So that's why we were doing that. Well, here's what happened. After about 4 years, we noticed that the RFPs responses got smaller and smaller. So instead of having 80 responses, we'd have 60, or then 40, or then 20. And we finally went and talked to some states, and they said, we're overwhelmed. We can't respond to any more RFPs. So we're giving up these opportunities, and we were getting less ability to get the ideas we were trying to get out there and the resources and help we were trying to get out there, and they sort of stopped paying attention to us. So it had an unintended consequence. This was a practice, not a law or a reg. It was just something we were trying to do. Congress has made a decision that we have to live with, that certain grants of the federal government only can go to nonprofits. Well, I don't know about you, but the distinction these days between humongous nonprofits and businesses is very slim. So the way they operate, what matters, et cetera, is difficult. And so this now has an unintended consequence that some of the best people who are in business trying to do the right thing, you can't get money to them. So these are unintended consequences that we have to look at. Let's go down to the 55 or less speed limit. How many of you remember that process? Remember that? Every state had to go through bringing their miles per hour, their speed limit down from 70, 75, or in some cases, Montana, Wyoming had no limits. Anybody from Montana, Wyoming? Oh, good. Yeah, some of those western states you can see for miles, so there was no particular speed limit. When they put into place the 55 per mile speed limit, it was because gas shortages were severe. Do you remember that? And there was pretty good research that if you went slower, you saved gas. Well, what happened after a while is the trucking industry said, whoa, 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 this is costing us humongous dollars because it's taking us longer to get across the country. We need you to change this, and the gas shortage got less severe. In fact, it just went away. And so the secondary reason for doing this, which was to save lives, got ignored. If saving lives had been the primary reason driving this policy, it might be that the trucking industry wouldn't have won. But in fact, they did win, and they got the law repealed. So it kind of had an unintended consequence. Now, not considering the presidential nominee for the Supreme Court, anybody guess what kind of unintended consequences that might have? You could think of all kinds. We won't go there. All right, so why do policies get made? Theoretically, policies get made either to improve life, so health, wellness, the stuff that you all are working on, to provide security, safety, to lower or contain costs. In many, many cases, policy are driven by cost issues. And I think that's really true in your world, and I'm sure that you are aware of that. If you're not networking with health economists, you're missing the boat, because costs are really driving some of these issues these days. Protecting a resource or a right, or as we said earlier in a different way, in some cases, policies are made just to exert power. It's because I can. It's because I have the power over you to do that, or I have a power to change your behavior. Sometimes we want to send a message. Sometimes we want to prevent others from winning. I would suggest the nominee thing had something to do with that. Or because I think I'm right, or because I want to win an argument. So again, the point I'm trying to make here is understanding why policies are made and what's behind them is really critical. And you cannot assume what it says on its face is what's really meant. All right. So this all leads up to something you all know. And this is a quote, thinking of policymaking as being about power. So think of policymaking as a struggle between groups with competing interests, some in favor of change, others opposed to it, depending on their interests or ideas. Therefore, understanding policymaking requires the understanding of the nature of power, not just who has it, but the nature of power, and how it's distributed and the manner in which it's executed. Okay, here is the cynic in me, or the political scientist in me. There was a major political science concept and structure that came out in the 1936, I believe it was, that said simply that politics is about who gets what, when, and how. So that's the nature of power. And politics happens in individual situations. It happens in schools when you're trying to get physical education through. It happens in all kinds of human endeavors, whether we like it or not. Power is the power to do something or to require somebody else to do something. It can be the power to prevent something or the power to shape preferences. So power is thought control. If I go back to the example of children getting lathered up with sunscreen, helping people think about that differently and think about trying to prevent skin cancer 35 years from now, 40 years from now, is the power to shape people's understanding about what needs to happen or what should happen. All right, so here is the beginning of the heart of the matter that I want to convey to you, and that is, if you look at policymaking as both process and product, so we tend to think of policy as the law or the reg or whatever, the practice. In fact, there's a lot of process that goes on in there. Some of it is obvious and some of it's on the face. Some of it is not. So how the definition of the problem you're trying to solve, or one is trying to solve, really matters. And the way that you build agendas to get that done, both to define the problem and to do the policy work, really matters. We have a tendency, myself as an executive in government, academicians, other people who are really trying to be data-based in their thinking and evidence-based in their work, they have a tendency to think that the analysis of options, the evaluation process, and the determination about whether to continue or to change something based on the data, we have a tendency to think that those are the most important places to make policy difference. I don't think so. The most important places are how the problem is defined, what it is we're trying to solve is, I think, one of the biggest issues, and then who we build the agenda with to do that. So let me give you some examples here. Problem definition. We can do research to try to help them define the problem. I think research helps. I don't think Congress sits around and says, what's the best research to solve some problem? First of all, they have to believe there's a problem. And secondly, it has to be defined in such a way that it involves you. It has to be, and I'm going to give you some examples of this from my world of behavioral health. So research can help with defining the problem. It can help with policy options analysis. It can help with implementation. It can actually help with options and power brokering. But really, when it gets down to it, is knowing who has the power to define the problem and build the agenda to get it addressed and to decide what policy options are going to be considered, and then what's driving that person or that institution to do what they're doing. That's the real work of policy and networking. And it's not quick. It takes a long time. So networking with the right people at the right time in the right way is going to have a lot to do with whether you can get your policies implemented or not. So I want to argue that you should be looking for alternatives in all of these areas. So anytime you see a problem that's defined in a certain way, think about how it could be defined differently to include you, or include what you know, or to define something in a way that you can bring forth issues. So let me give you a couple of examples here. When I was in the 1980s, I was head or secretary of mental health for the state of Ohio. In those days, it was about 2 decades after the beginning of the deinstitutionalization process. You've all heard about that. There were lots of debates and arguments about mentally ill people on the streets and deinstitutionalization having caused that, and we had to fix it by reinstitutionalizing people. Well, you can imagine this was a lot of back and forth and debates and arguments, et cetera. I got to be involved in some research that we did in Ohio in those days, which was really very cutting edge. And to make a long story short, what we were able to do with the research is redefine the problem to be about housing, the cost of housing, homelessness, poverty, et cetera, not about whether or not somebody had been let out of a hospital appropriately or inappropriately. If you take someone with a serious mental illness and put them out on the street with no support, you're probably going to get a homeless, crazy person walking around on the streets. That doesn't mean letting them out of the hospital was the wrong thing. So we redefined the issue, and it really didn't solve homelessness among people with mental illness, but it certainly has changed the policy discussion about what to do about it. So we do a lot of work now in housing policy, a lot of work now in poverty issues, support employment issues, and other things. So changing the way the policy is defined has a real impact. Today's opioid addiction and overdose. This is a big one that I lived through. I'm still watching it from a distance. There are a lot of people in DC who wanted to describe this problem, define this problem of growing opioid use, growing addiction, and growing overdoses as a prescribing problem. The problem was the doctors were prescribing too much. The dentists were prescribing too much. The emergency rooms were prescribing too much. The vets, frankly, were prescribing too much, and it sat on the shelves and people could use it. So they started doing things about requiring physicians to be trained more. They talked more about limitations on the amounts prescribed. We set up all kinds of national registries so we could identify who was getting what medications, and we essentially made it harder to get prescriptions. The problem is, once it gets harder to get prescriptions and you're starting to get hooked, you're going to go get cheap heroin on the streets, and you create a growth on the illicit side of this problem. On the other hand, if you define this problem as a law enforcement issue, a demand reduction issue, you're going to work with police, you're going to work with Mexico, you're going to work with all kinds of international issues, and there's lots of prescribing that is inappropriate that's going on without being touched. We had to redefine this problem as a broader public health issue. That made it more difficult, it made it harder, it made it not as easy, but it also meant that we weren't just targeting the doctors, so the AMA settled down. It meant that we weren't just targeting law enforcement. So the Department of Justice became not the only player in the problem. So by redefining what this problem was, I think the country now has a comprehensive approach to how to address this problem, but it had to do with how you define what the problem is. All right, I want to talk a little bit about opportunities. So these are the cutting edge or frontiers for kinesiology. And I really want to make this case because I hope I can convince you to get more and more engaged in some things I know you're already engaged in. I can tell by just the discussion in the room, but more opportunities that I think you have not yet taken advantage of and you could. So you know about the federal government's triple aim. Everybody know about that? Better health care, lower costs. A lot of work going on in those three areas. The Let's Move initiative by the First Lady is a very good example of federal government-wide trying to get at better health. And you clearly should be, I assume you are, sort of part of that initiative. There are a ton of diseases that the federal government has targeted for, sorry, they gave me water and I'm not using it. I got it, Kathy, thank you. So the federal government has looked at the data, looked at how many people are dying from, having complications from some pretty major diseases. Hunger issues, which is not a disease, but hunger issues, and its connection to obesity, diabetes, et cetera. Heart disease, hypertension, Alzheimer's, all these are areas that the federal government is trying to say, my goodness, these are driving costs of healthcare, so how can we bring them down? Depression and schizophrenia, which I'm going to talk a little bit more about because something that I know something about. Pain management without opioids, my goodness, I hope to heck you guys are heavy duty into that area. How would you use movement and exercise and fitness and other kinds of things to manage pain in some cases? Traumatic brain injury in athletes and veterans, the cancer moonshot that they're working on. These are all things that the federal government under this administration has really defined as problems to be solved. And your ability to be inside that and defining it in a way that includes you is really critical. The aging population, the role of behavioral health in healthcare, and I will say more about this in a minute. I've already said a little bit about the trauma issues. I am convinced, maybe it's my value set, but I am convinced that health, fitness, everything that's an alternative to the traditional medications, surgery, that kind of thing, I think we haven't done nearly enough about in managing trauma and managing the effects of trauma, et cetera, and I'll say more about this in a minute. There's new research going on about first episode psychosis and the prodromal syndrome before that first episode. This is about kids. This is about young adolescents, 14, 15, 16 to 25, and what they're experiencing, and can we change the trajectory of that disease once they've had a psychotic event? And we know that we can. We know there's some things that we can do. What I have never seen is any discussion about the role of exercise, movement, fitness, health in that trajectory change. And I'm convinced we could do more there. I'm just not the expert. You are. And so we need you in that discussion. NIMH is leading this work. You really should take a look at it if you haven't. The Brain Initiative, I'm going to say a little bit more about. The Adolescent Brain Cognitive Development Study, if you haven't seen that, man, you should be in the thick of that. And again, what I want to tell you, as a federal official who believes in this, I would have been very open to a group of kinesiologists coming to me and saying, what do you think about putting us in there? What do you think about defining this problem in a way that I would be there? I don't remember ever getting a call from a kinesiologist. So that's not to blame you. That's to say there is a whole wealth of opportunities here that I think you may have not yet taken advantage of. And then the Precision Medicine Initiative, I want to say just a little bit about as well. I'm going to skip this in the interest of time because I think you know a lot about this area. It's just an example of, if you look at the way the diabetes issue is defined and what the outcome you're looking for is, it might really change what you do about it. So the policy that gets made about it. And in this case, policy is law, but it also could be payment decisions and other kinds of things. All right, you all know about the Brain Initiative, right? No? Okay. The Brain Initiative is called the Brain Research Through Advancing Innovative Neurotechnologies, or BRAIN. It was announced by the president in 2014, and the idea or the problem they're trying to define or solve here is to increase understanding of the brain and its work and its neurological processes. Typically, what they're looking for is medicine, radiology, other kinds of reactions and impacts that they can change based on what they learn about the brain. The brain is the frontier of our bodies. So I'm going to show you some pictures here in a minute that I suspect you know very well, but they have to do with different impacts of things on the brain. I think there's an incredible opportunity for you to be in the middle of that if you get into the right places. There's a multi-council working group. I did not see the National Academy of Kinesiology on that group. It involves a lot of other kinds of professional groups. Now, I'm not making a case here for whether the Academy wants to do this or not. I'm making the case for whether or not kinesiologists ought to be part of this conversation in a much more blatant way. There's a new part of this called the ABCD study. This is the Adolescent Brain Cognitive Development Study, which NIMH is leading. They're going to have 10,000 young people signed up to this study, and what they're trying to understand is how does brain development change over the adolescent experience, and how does things like sleep, exercise, exposure to drugs, and other kinds of experiences in adolescence, how does that change the way the adult becomes after adolescence? This is like an opportunity. It's like on a platter. if you're not in it, I would heartily recommend that you find the way to get into this. This is something that just came out in January. This is what's called the schizophrenia skyline. This one gene here, which is called, I think, C4 or something like that, shows the runaway pruning of a teenager's brain, the communication structures in a teenager's brain that relate to the way that schizophrenia then manifests itself as seeing the world differently, hearing the world differently, experiencing the world differently. This is cutting edge efforts, and I think it's terrific. But nobody that I know of is asking the question, how does movement, how does physical fitness, how does physical activity, how does it have an impact on this? What they're looking at is how do medications have an impact on this? How can prevention help? And frankly, how can you get in sooner, and how can genetic approaches make a difference? Those are all important questions. They're not the only questions that should be asked. And if you're not asking the right questions, nobody else will ask them for you. All right, so these are just some examples. Just in the last year, these are articles or press releases that have gotten out about biomarkers, about genetic risks, about markers, genome markers of lithium, which is a medication for depression and bipolar. How do those things get done? There is so much exploding in the area of the brain and the impacts of medication and other kinds of medical interventions on the brain. I want to know about the implications of the work that you do on the human brain, on the adolescent developing brain, et cetera. So, pictures. This is schizophrenia. You've probably seen some of these, but this is on the left. Males are on the top. Females are on the bottom. The schizophrenic males and females are on the right. Basically, the point of this picture is there's a difference in the brain of a person with schizophrenia. What we don't know is when does that start and how does that start and what can make a difference in that trajectory. Okay, so here's drug use in the brain. You can see cocaine at the top, methamphetamine, alcohol, heroin, and each one of them you can see on the left the control or normal brain, on the right an addicted brain. You can see the difference. Okay, so the brain is being impacted by these things. We also know something now about the way the brain is susceptible to addiction in many cases, just like the genome or the genetic issue on schizophrenia. Now, why am I showing you this? Well, this shows treatment. So a normal control on the left of a normal person, a meth user 1 month in, and 1 month into detox, and a meth user 14 months into detox. The point of this picture is that the brain can get better. The brain can actually heal. We don't know if it can get all the way back, but we do know it can change back. And so there's pioneering stuff, and we've known this one since 2001. This comes from some research that the head of the National Institute of Drug Abuse has done. So we know that there's stuff going on in the brain in my area. Depression. I know you know this. The person on the left is depressed. The person on the right is not depressed. Obviously, the brain is impacted by depression. You know better than anybody, if there's anything we know, that exercise works or exercise helps with depression. Okay, so we know that. This is the effects of exercise, and again, these are just pictures to show that the brain changes with these impacts. Now, what I want to know is how do these 4 pictures fit together? How does the changes in the brain by exercise, and the changes in the brain in depression, and the changes in the brain in schizophrenia, and the changes in the brain of drug addiction, in my world, I want to know that. Nobody's asking that question in quite that way. And I know some of you may be working in this area of impact in mental health issues. This is an area that I think it could be exploding with the new Brain Initiative and with your interest, and I really encourage you to do that. Brain and exercise. Okay, so now we know that exercise makes a difference in the brain. How do we put all these brain pictures together? I don't have an idea. I'm not a brain person and I'm not a kinesiologist, but I bet you somebody in this room can help figure that out. All right. These are just also, I'm going to skip that just for interest of time. What we are learning, there is some new research out about and the impact of exercise on addiction, the impact of exercise on schizophrenia. It has a tendency to be the impact on the treatment or the outcomes of treatment. I really want to see what the outcomes are, what the preventive implications are, way back when that adolescent brain is developing. Down at the bottom, SAMHSA runs something called the Alternatives Conference. It happens every year. When I was SAMHSA administrator, I got beat up royally by Congress for doing it because we weren't focusing on medications, we weren't focusing on the traditional forced treatment. We were focusing on alternatives, yoga, meditation, exercise, sleep, nutrition, other kinds of things. I called my friends at SAMHSA this week and said, do you ever remember a kinesiologist participating in that conference? And they went back and looked. And the answer was, as far as we could tell from the records, we'd never had a kinesiologist in that alternatives conference. I didn't even know to ask until now, until I got a chance to come talk to you. So how do we network together so that somebody like myself who was open to your message and somebody like you who's got information I could use, and frankly, I would have loved to have had some evidence to hold up to Congress to say, look, there's a good reason for talking about this stuff. But at the time, I didn't have it. So I'm suggesting that networking with unsuspecting people or with non-traditional folks may be really something you want to consider. All right, anybody know about ACEs, adverse childhood events? This is sort of the quintessential trauma work that's going on by Kaiser, by NIH, by CDC, all across the country. What we know now is that trauma happens to every kid, and we know that the more trauma, simply put, the more likelihood of adult impacts. And those adult impacts are in things like more smoking, more alcohol use, less exercise, missed work, obesity, diabetes, depression. It's not just mental health reactions, it's actually health reactions. We don't know precisely how that works. We do know there's some protective factors, but we don't know precisely how it works, and we sure as heck don't know how it works in the brain. We know that trauma affects the brain. We don't know how to prevent that or to change that through some of these interventions. Earlier death, it has a huge economic toll, so ACEs, watch for that, is an emerging set of research. And this diagram says a little bit about the way people think that this works. But if you look at it, we think kids have adverse childhood experiences, and this could be things like divorce in the family. There's lots of kids that have divorce in the family. They grow up just fine. But there's also kids that have divorce in the family, domestic violence in the family, alcohol abuse in the family, untreated mental illness in the family, and you go on, and it's sexual abuse for themselves. You go on and on. The more traumatic events in childhood, the more likelihood of having some of those impacts. So if you looked at, this is what they think. Adult childhood experiences leads to disrupted neurodevelopment. That leads to social, emotional, and cognitive impairments. That leads to adoption of health risk behaviors, disease, disability, and social problems, and ultimately to early death. I would guess that some of you in this room could tell me where movement, fitness, health, exercise would fit on that pyramid to impact and create some protective factors for a lot of those issues. It's a major opportunity for you that I encourage you to get into. These are just some of the evidence-based protective steps. The reason I put it in there is because almost every one of those you could implement with children through sports and physical fitness and physical activity. So when we get into these arguments about whether we should take phys ed and art out of the schools, nobody's, well, I shouldn't say that. You guys are doing it. But policymakers aren't thinking about it as this has something to do with affecting future health. And this has something to do with affecting behavioral health and drug use and mental illness and homelessness and other things. They're not thinking of it that way. They're defining the problem as a pure cost issue or a pure value issue. Reading, writing, arithmetic is more important than physical education. So redefining the problem, connecting with those people who are your natural allies that may be in unusual places, these are all things that I am trying to suggest that you think about. The Precision Medicine Initiative, anybody heard about that? Good. It's called PMI. One of the things that NIH is actually trying to do is to sign up like 1 million people across the country to follow their health records over time, to start making some genetic understanding, genetic combined with environment, combined with experience. So genetics, environment, experience. The theory is those three things together is what would make the difference between not just whether I give you 20 milligrams of a med and I give you 30 milligrams of a med, but much more specific individual approaches to medication or to health management, health condition management, and even prevention. This is another area where I never saw anybody talk about the health issues or the fitness issues, the movement issues, the exercise issues. It's really all about medication, surgeries, radiology, those kinds of implications. I think this is an opportunity for you to understand about it, think about it, to get into it, figure out who's running it. And there are advisory committees on each of these things I'm telling you about that really do have an impact. And I kind of went through and looked. I didn't see anybody at least designated as a kinesiologist on any of these advisory groups. I saw none of that. Now, is there a psychologist on there who's working in kinesiology? Perhaps. You sure couldn't tell it, though, from what's showing in the work that they are doing. All right, so examples of groups to influence or use. So getting into places you're not used to getting into and being in, I really want to encourage you to think about. There are things like the Medicare Payment Advisory Committee. They advise Congress on Medicare payment issues. And with the aging population, what's in that and what they think about is huge. The U.S. Preventive Services Task Force, anybody know about that one? USPSTF, it's said really quickly. It's another one I looked at. Well, I wonder if, because I dealt with them all the time. I never saw a kinesiologist in there. I never saw them or heard them talk about what's the science for the prevention of certain diseases or issues or health promotion by movement, by exercise, by other things. I think it's a major opportunity for networking with not just being on that group, although you could argue to try to be that, but figuring out who's on that, figuring out who knows that person from that university, figuring out how to make those connections and make a difference. There's a PMI or Precision Medicine Working Group. There's a working group for the Brain Initiative. The Cancer Moonshot Task Force is a group that you could try to impact. There are obviously corporate and public and private partnerships that you could impact on some of these Healthier America kinds of efforts. Federal agencies and task forces. I had 7 in a little tiny agency. Relatively speaking, SAMHSA is a small agency. I had 7 advisory committees, and people applied to be on them. Never had a kinesiologist ask to be on one. I think these are opportunities for you to network with, get to know other people, figure out who cares about stuff. NIDA, National Institute of Drug Abuse, has an advisory committee. So does NIMH. My point here is not to just push behavioral health, although that's clearly what I come from, but to get you to think a little bit about what's unusual and who might be able to help and touch your issue and you theirs in different places than you normally think. Best practices clearinghouses. SAMHSA also runs something called the National NREP, National Registry of Evidence-Based Programs and Practices. I now know that there are some programs and practices, because I did the speech, that there are now programs and practices that are evidence-based around exercise and mental illness. I never had a program come and ask to be reviewed for NREP from that perspective. So that's just an example. The Department of Justice has one. The University of Colorado at Boulder has one. And these are just about behavioral health issues. There's a jillion things like this out there that if you're not thinking about and touching, you're missing opportunities to make a difference in policy. Local groups. I suspect a lot of you are working in this area, states and schools and local issues, but sometimes you don't think about things like King County Opioid and Drug Addiction Task Force. Another area where a local, who's on there? Local officials, local politicians, providers, Didn't see any kinesiologists, didn't see anybody asking to go on there because they knew something about how to help treat or prevent opioid addiction or pain issues through movement, exercise, health, etc. Bernalillo County's got and here in New Mexico's got a behavioral health subcommittee set of groups. There's a group in Boone County, Indiana. Anybody here from Indiana? Great. Do you know this group? This is the Childhood Obesity Task Force. I'm sorry? You don't? This one's really interesting. I don't know a lot about it, but what I was struck with about this is sort of their mission. We want to ensure that movement occurs and instill that as a lifelong value in our children. I never heard anybody talk about it that way until I saw this particular local task force. So there's opportunities locally, state, federal, national that you could get into and network with. I want to sort of, I'm getting close to ending here. I want to just give you an example of something that struck me as, again, why didn't I see kinesiologists involved in this? There is, you probably know much more about this than I do, supervised exercise therapy. It's a therapy for patients with peripheral artery disease. The American Heart Association actually wrote a letter to CMS, that's the Centers for Medicaid and Medicare, to ask for a coverage determination for SET. There was nobody else with the American Heart Association on that letter, and it was a completely peer-reviewed, evidence-based letter about asking for this. If CMS agrees with this, this basically means federal programs will cover this. So it's a payment issue, a big-time payment issue. You will notice very quickly, comments are due October 15th. You have all of, what's today, the 6th? You have all of 9 days to get your comments in about that. And once I think somebody like the American Heart Association or CMS sees you as an organization or you as associations put in comments that make some sense in these areas, I think you will open up incredible opportunities to network and find out who else is doing things that will impact your world. The proposed decision on this is March 15th of next year, and they would release actually the completed thing in June. So, but you've got just a few days to make comment and maybe follow this over the next few months to see where else you can make an impact, or maybe call up the Heart Association and say, how can I help? Where can we work together on this? All right, so I want to end with just saying there's some policy challenges that I guess I would think of really more in some ways as suggestions, and they're going to seem fairly obvious again, but first of all, believe that you can make a difference. And it's not just in your research area, it's not just in your area of comfort, your comfort zone, but you can make a difference. You have some real information to provide to the healthcare world and the health and well-being world that's not always getting out beyond your existing networks. So you want to get out beyond that and start looking strategically at who you can do that with. The second thing is study and provide information about what matters. And by that I mean, think about who's defining the problem, what's driving them, what they want to know, not just what your area of interest or research is. So you got to think about how you're going to make that input and how are you going to provide data to that process. Look for some unexpected opportunities because they're out there all over the place. I've given you some examples hopefully tonight. Identify the problem to be solved. If there's anything I've tried to make the case is how you define the problem is going to keep you in the process or out of the process. And I think there's a lot of redefining that could go on. Understand who is involved and has the power and what drives them. I've said that 50 times, but the point here is it is about power. It is about who can make the decision. It is about understanding who that person is, what's driving them, why it's driving them, and where you can make a difference. Be pushy, be persistent, and you do have to be patient. It does take an awful long time to build the relationships. Just a cold call to Congress when they're dealing with a law that you like or don't like isn't really going to get it. If I had, and all the times I was in front of Congress and they were beating me up about something, I never once saw them try to put a provision into a mental health bill about making sure that people with behavioral health needs had more opportunities for exercise, fitness, physical activity, et cetera. And yet, they die earlier, They have more heart disease, they have more diabetes, they have more obesity, they smoke more. There's a ripe opportunity to make a difference in their lives. And Congress wasn't talking about that. They were only talking about forced treatment or law enforcement and other kinds of issues that we were trying to say, okay, that's an issue, but it's not the only issue. All right, so let me end there by just once again saying thank you. I appreciate you letting me say whatever I wanted to say here this evening, and I hope that if nothing else, even if I can't suck you into the behavioral health world, at least I can get you to think a little bit about different areas that you might be able to get into, meet people, learn people, build relationships, because when you need to push the policy button, it needs to have the relationship already there. Thank you. Really appreciate it.